Kia ora koutou,
Yep.
and welcome to our webinar this evening, exploring an array of urology topics. My name is Lucinda Thatcher, and tonight I welcome Jim Duthie, who is a specialist urologist based in both Tauranga and Wellington. He specialises in prostate treatments, and we're very grateful to have him here this evening to discuss urology in 60 minutes. Our session is supported by the Section of Rural Health Department of General Practice at the University of Otago and the Royal New Zealand College of General Practitioners, notably the Division of Rural Hospital Medicine. We are endorsed for 1 hour of CME, so please update and fill in the evaluation form at the end, along with your medical council number, and I can lodge these CME points for you this evening. Please be interactive. Ask questions within the chat, and we will certainly put them towards to Jim as the evening is going on. Thank you to Ralston for joining me this evening and helping us with that. Always much appreciated. So now, without further ado, I will hand over to Jim. And thank you again very much for giving us your time this evening.
Oh, it's a pleasure. I'll try to stay awake. It's the end of a long on-call week. So if I start slurring my words, I'm just tired. I'm not otherwise impaired.
That's my job. I'll keep you awake. Don't panic.
Well, good evening, everybody. Yep, Jim Duthie's my name, and I do quite a bit of prostate work. I did my fellowship training at Peter MacCallum in Melbourne in robotic prostatectomy back in 2012. And I've been the medical advisor for the Prostate Cancer Foundation since I got back in 2013, and also the New Zealand representative for the Australasian Prostate Cancer Outcomes Registry. I work with November, and I'm the Testicular Cancer New Zealand medical advisor as well. So ask me any questions about that stuff. So I'm not going to make this all about prostate. I had a good chat to Lucinda, and we've tried to make this a bit of a balance between true rural GP and some rural ED stuff. So if you have to zone out and play solitaire for this first few slides, I understand, but this is to give you a bit of a refresher on the anatomy, which will explain some of the pathology that we'll be talking about later. Can you see my arrow moving on the shared screen? Great.
Yes.
Okay, so this is a really good anatomy diagram apart from the fact that it's labeled wrong. So don't worry so much about the letters. The reason why I've got this is just to illustrate how we've got this yellow area around here called the peripheral zone, and this blue area here, which is actually the transition zone. And those are clinically important because 80% of prostate cancers grow in the peripheral zone. And the transition zone is the only part of the prostate that gets involved with benign prostate hyperplasia. So you don't get BPH of the peripheral zone, but you do get most of the cancers there. And you can see that the transition zone is pretty close to the urethra. And as it expands, it wraps around the urethra. So it can kind of compress from all angles. And when I'm talking to patients about this, I give the analogy of a watermelon for prostate anatomy, where you've got a green capsule and the prostate has a capsule. The white rind is like the peripheral zone, and the red pulp is the transition zone that fills up the space in the middle part of the prostate. And unfortunately, anatomically, we've got the urethra running right through that transition zone. So it tends to get affected by BPH. So looking at it in a sagittal view, prostate's here sitting underneath the bladder and hard up against the rectum, and that's why it can be worthwhile to do a DRE, because you're actually feeling, if you reach around the prostate either side, you're feeling most of that peripheral zone. So you've got a better chance than you should have of picking up prostate cancer with your finger. And that'll also give you an idea of the size of the prostate, which can be clinically relevant. If you want to know more about prostate cancer screening, I did a whole talk on this for the Goodfellow lecture series last year in August, I think it was. So I'll go into that with some detail. There has been a question about PSA screening, and I mean, I spent an hour just talking about it. The punchline is we had our guidelines written in 2015. We were committed to reviewing those guidelines in 2020, but it hasn't happened. The Ministry of Health just hasn't pushed for it yet. I've done some consulting on them, but those guidelines aren't coming out in a hurry. But what's happened in the interim 10 years is data has matured, and we're much more confident of the value of PSA screening now. So it seems like it's the most effective screening program you can have in terms of saving lives and minimizing harm compared to, like, it's significantly more effective than mammography, for example. So Europe is rolling out a trial called the Praise U trial of tailored prostate cancer screening. So it's not just a cutoff of four for what's normal. It's age adjusted, it's personal risk adjusted, and it involves MRI scanning. So it is worth doing PSA screening. We're far more confident of that than we were back in 2015. So in terms of, just to wrap up the prostate cancer screening part, is it worth doing a DRE with your PSA? Well, if it's a deal breaker for any individual patient that they won't have prostate cancer screening if you threaten them with a DRE, then don't do a DRE. But there is added value, and there might even be one or two people on this session tonight who have picked up an early prostate cancer on DRE in the presence of a normal PSA test. So that's not common, but it'll happen once or twice a year, every year for me, that I'll get a referral with a normal PSA and an abnormal DRE where a doctor has picked up the cancer before the PSA has. So is it essential that you do a DRE? No, PSA screening is adequate, but it'd be a lot cooler if you did do a DRE. Okay. So just to wrap up the PSA screening stuff, we've got not only better at using PSA as a tool, but we've got better biopsy and treatment tools than we had back in 2015. So back when I was a registrar, the only tool we had was trus biopsy, transrectal ultrasound guided biopsy, which has 50 to 70% sensitivity. So basically a coin toss as to whether or not you're going to pick up a cancer if it's there, and no ability to pick high grade significant cancers over low grade insignificant cancers. So since then, MRIs come in a big way, and that's the most useful tool that we've got for ruling out people who don't need a biopsy. It's very good at overlooking low grade cancers that don't clinically matter, and it's very good at picking up the high grade ones. So 90% sensitive. And you haven't stuck a needle into somebody, so no risk of sepsis, no discomfort. All they've had to do is lie still for a minute. On top of that, given the option, I don't do trus biopsy. I do transperineal biopsy, where we sterilize the skin. I do this under a GA when I've got the option, and we use this grid a bit like battleships, lined up with the MRI scan so that we know exactly where we're aiming. So really makes it a much more elegant procedure. You're not just turning the prostate into Swiss cheese in the hopes you're going to pick up cancer. You're actually targeting specific lesions. So I don't want to go on about that too much, but in terms of treatment, radiation's got better, but also we've got robotic surgery far more available than it was. We've got the first surgical robot available in the public system in Auckland now. It's been there for about a year. We're more than 12 years behind Australia. When I left Australia at the end of 2012, beginning of 2013, every state had a publicly accessible surgical robot, and we got our first one about a year ago. This is a picture of the Hugo made by Medtronic. This is going to be the game changer. So this is a competitor to the Da Vinci platform. They've basically had a monopoly for a generation, for 25 years. This robot, you can do the same operation for $9,000 to $10,000 cheaper per case. It's getting cost neutral with laparoscopy, so way, way cheaper. And I just did the first robotic prostatectomy in New Zealand on this thing last week, and it was fine. It's just as good as the Da Vinci. So leaving that behind, I'm going to move on to BPH. And again, we won't dwell on this too much. I think it is useful in the GP setting. It's maybe not so much in the ED setting. The point of this diagram is to show that basically all men will have some histological BPH if you do a biopsy on them. So really common, and it increases with age. Whether or not the prostate gets enlarged, that doesn't always happen. And I'll show you a slide that explains why you can have significant symptoms with a small prostate. Bladder outlet obstruction is a urodynamics test that we don't commonly do on men because we don't need to. It's a clinical diagnosis in most cases. But then there's also not 100% overlap with bladder symptoms. So you can see that most guys have got BPH. Not all of them are bothered by symptoms by any means. The important thing on this is that enlargement versus the symptoms and the BPH thing. So some men with small prostates will have bad symptoms and they're not making it up. It is to do with bladder outlet obstruction. It is to do with the increased tone in the urethra. So again, if we go back to this picture, urethra is running right through the middle of the transition zone. So it makes logical sense that if you are expanding this tissue, it's going to squash the urethra like kinking a hose. And that's a really easy way to explain it to patients. You've got this mechanical compression, and of course, your flow is going to slow down. It's harder to get started. Your flow is going to stop and start. You'll have dribbling at the end. But really, the more important thing is that you've got smooth muscle in that prostate, which is increased in tone. So even a small prostate can be tightly strangling the urethra. I operated on an old med school professor of mine a couple of years ago who had a very small prostate and very bad symptoms. And he said he felt like a fraud. And then once I explained to him, no, this is smooth muscle tone, he felt a lot better about it. And this is, of course, why we give alpha blockers, because they work on smooth muscle to relax them. This is a picture that's got not only the alpha blockers, but 5-alpha reductase inhibitors. So that's finasteride, showing how they work in different ways. So we most commonly give an alpha blocker for a couple of reasons. One, most men with bladder symptoms related to BPH will have increased muscle tone. So alpha blockers will work for most men. They also work pretty quickly. Only takes a few days for you to really notice a difference. Whereas the 5-alpha reductase inhibitors, finasteride, dutasteride, they take 6 months to reach full clinical efficacy. When they do get up to speed, they can shrink down BPH by 50%. So if we end up doing a TURP on these guys, they'll have less bleeding. It'll be a quicker procedure, less prone to complications. But it's in for the long haul. It's also not free from side effects, the 5-alpha reductase inhibitors. So men can get breast tenderness. They can get erectile dysfunction, and that can be irreversible. So that happens to 5 to 8% of men, which is not a high proportion, but if you're talking about a younger guy, then that could be really significant. The other thing about 5-alpha reductase inhibitors, you have to have a reasonable amount of BPH because they work by shrinking down the size of the gland. So if you've got one of those small prostates with a lot of muscle tone, they just don't work. And the cutoff is 40 cc's. So if you do a DRE and a guy's got a really small prostate, it's not going to help to start him on finasteride. And unfortunately, a lot of the public hospitals will have it in their guidelines that you've got to have men on an alpha blocker and finasteride before they'll see them for bladder outlet obstruction. But I mean, I think the easiest thing to do is if you know that they've got a small prostate, or if erectile dysfunction is going to be a big deal for them, just say, I talked to the patient, they don't want it. And that would, if you explained it to them, that would be the truth. I wouldn't want it. So getting a little bit more ED oriented, this is a picture of somebody in acute urinary retention, slim guy, so you can see that he's got this huge volume. I was telling Lucinda a little while ago about how my personal record was a guy who had 7 liters in his bladder. He was somebody who was intellectually disabled, living in a rest home, and was seeing their GP regularly for incontinence and was being prescribed antibiotics empirically, and then finding that nothing was growing on the MSU. So that was overflow incontinence. Now, there's a big difference between acute retention and chronic retention. If somebody's in acute retention, it'll tend to be smaller volume, kind of, 1 liter, maybe less, and it'll tend to be painful. It's like, tying a shoelace around the urethra. You'd very rapidly get uncomfortable with a bladder that's being acutely stretched, as opposed to chronic retention, which happens when people have a post-void residual volume of maybe 50 cc's, and over time that increases, and it can be liters, and it can be insensate. So the thing to do is examine them. You can often feel a big bladder like that. And it's particularly important that you do that with the key symptom of nocturnal incontinence. That's a classic for overflow incontinence. But anytime a man's getting UTIs, it's worth putting a hand on their tummy to see if they've got a big palpable bladder. Now, Acute retention, they're in pain, they need to have a catheter before anything else happens. If it's chronic retention, they don't necessarily need a catheter. If they've got no renal impairment, if they've had an ultrasound that shows a big post-void residual but no hydronephrosis, if they're not getting UTIs, don't have a bladder stone, and it's asymptomatic, it's better to just refer them for disobstructing surgery. There's no particular reason to put a catheter in before you do that. Okay, so definitive treatment. This is a TURP procedure. So we've gone up the urethra under an anesthetic and we're just chiseling out that transition zone with the intention that you get all of the transition zone. So what we tell our registrars, the teaching is you keep going until you see the horizontal fibers of the prostate capsule. In real life, you never see that. And I tell my registrars, what you do is you keep chiseling away until one, you lose your nerve, or two, you make a hole in the prostate and cause significant bleeding. So it's much more common that we will leave transition zone behind, which means that we're not completely disobstructing. We're more likely to need it to do another procedure when that transition zone grows back in the future. So the gold standard, according to all of our international guidelines, is actually prostate enucleation, where we use a laser to get into the tissue plane between transition and peripheral zones, and we shell the whole thing out. So that's more effective for reducing symptoms and more durable. It also causes less bleeding. It's technically quite tricky. I teach laser enucleation. The learning curve is about 80 cases, but once you're over that learning curve, it's a very rewarding operation. You can see that you're taking out a lot more tissue than with a TURP. What I'd say is that there's evidence that laser is better for any size of prostate, but the difference in outcomes really diverges with increasing volume of prostate. So if you've got a prostate volume of, say, 50 cc's or less, you're not going to make a huge difference by having a laser. But if you've got a prostate volume of 100 cc's, you really are. So if you've got access to a laser, you should be using it for the bigger prostates. Now, one thing that's we've discovered in the last few years is that men who had TURP procedures in the 1970s had better outcomes than they do now. And the reason is that we're taking longer to do TURPs because we've got medications. And what we've discovered is that medications treat symptoms of BPH, but they don't slow the progression of detrusor damage that the BPH is causing. So blocking off the urethra means that the bladder has to work harder. And I'll explain it to patients like, any muscle that has to work out is going to become bulky and twitchy. And so the bladder wall becomes thickened. And we're seeing that on ultrasound here. You can get these diverticular where you get blowouts. And I say to patients, it's like the bulge in the side wall of a car tire. It's a weak point that's getting expanded. And this is trabeculation. This is cables of muscle that we can see on cystoscopy. And sometimes they even pick this up on ultrasound because it can be so marked. So those are objective findings of detrusor dysfunction. And these are ubiquitous in the guys that we see in clinic at the hospital. Guys who have already been on an alpha blocker for a couple of years, progressive symptoms, they've all got detrusor dysfunction. Subjectively, we know that men are going through the same process of detrusor damage if they've got the triad of what we call storage symptoms. So your voiding symptoms are slow flow, intermittency, hesitancy, terminal dribble. The storage symptoms are to do with the bladder having to store urine. And the three storage symptoms are going more frequently, going more urgently, and getting up in the night. So if men have got these objective findings or those three subjective findings, they're getting irreversible detrusor damage. And the right thing to do is a disobstructing procedure because that makes a difference for progression and medications don't. And when I was a registrar, the teaching was always, he's got to earn his TURP. You keep jacking up the dose of doxazosin until they just can't bear it anymore or they've gone into retention. Then you do the TURP because you don't want to do it too early. You might have to repeat it in 10 years. And in the short term, we usually stir up their symptoms. I tell men that I'm going to make you worse before you get better. But that teaching is all wrong. And it's kind of like saying, well, we're not going to treat your heart failure until you're actually coughing up pink foam. So you know that by that stage, the right heart's stiff, it's losing compliance, it's got scar tissue mixed amongst those muscle fibers, and you're just not going to have the same outcome as if you treated it early on. Any questions come up so far that we should stop and have a think about? Good to go?
No, just one about PSAs and with the MRI, but really we just do
Yeah.
the PSA first and then the MRI is a subsequent investigation once we've got an abnormal
Yeah. And there's certainly
PSA
isn't,
or
yeah, there's an argument for MRI screening. That's not going to happen in New Zealand. It's just so resource intensive. But yes, certainly a lot of hospitals will have a pre-biopsy MRI. Not all of them, unfortunately. That's the way it should be. And certainly if you've got a loved one with an elevated PSA, I wouldn't let them have a trust biopsy before having an MRI scan. As I said, in a lot of cases, you can avoid a biopsy altogether. Um, a classic would be we see a guy who's mid-late 60s, PSA's gone from 3.5 to 4.5 over a year. We do an MRI scan, it's all clear. We are 90% reassured, and all we'll do is follow up with another PSA in about 3 months' time. If it's not climbing, we can say, all right, well, the chances of you having an occult cancer are low, you're fine. But if the PSA continues to climb, we'll think, well, maybe this is one of the occult cancers, and we could do a template biopsy. So instead of targeting a specific lesion, we're just kind of covering as much of the peripheral zone as we can and a little bit of the transition zone to pick up those rarer cancers. Um, but most of those guys, you can avoid a biopsy altogether. And so because I MRI everybody in private, I do virtually no active surveillance of low-grade cancers in private because I'm not picking them up. Those guys I'm reassuring appropriately. They can live their lives without the curse of a diagnosis of an insignificant cancer.
yeah, that's a great outcome of it, isn't it?
Yeah,
We've just had
and
a
it's
sorry. We've just had another
no, go
question
ahead.
from the chat, more for inpatient rural hospital.
Yep.
Are on the ward post-void residuals helpful? Not sure what to do about them in terms of, I guess, urinary retention and things.
Yeah, and it's such an individual thing. So I think if you've got somebody who's come in with acute retention, and you might be talking about somebody who's maybe gone into retention, had a catheter placed, started on an alpha blocker, you're getting them back a week later to see how they're going. We like to have a good couple of 150cc plus voids without much of a post-void residual to make sure that they can go home without a catheter. And I think if you're doing that, you've got a bladder scanner available, sequential bladder scans is the way to go. So, they might be peeing 150, 180 mils, but if their post-void residual after each void has gone from 2 to 3 to 400, you're losing. Equally, there are guys who are walking around normally with a post-void residual of 3 or 400 cc's, and you'll see that on your ultrasound sometimes. So it is a little bit individual, and it's a tricky thing that a lot of these older guys have got a really high volume bladder. And when we're doing a TURP or a laser enucleation and doing a trial avoid the next morning, I'll often say to the nurse, look, this guy's got a huge bladder. He's got like a 1200 mil capacity. So don't be alarmed if he hasn't got an urge to go at 500 mils. Just, wait until he feels ready. Pragmatically, if it's getting late in the afternoon, people tend to fail the later it gets in the day. The best chance of a successful trial avoid is if you do it early. So the goal would be get the catheter out at 6 a.m. A really easy shortcut to take is to get the nurses to do a retrograde fill. So catheter tip syringe, 150 cc's of warm saline, put that into the bladder right before you whip the catheter out, and you've given them a head start.
Good
But I
trick.
would be if somebody's voiding okay, getting a couple of 100 mils out of every void, they've got 1 to 200 cc's in the bladder as a post void, which is stable. They're not in pain. They're able to seek help if they need to. I'd be okay with them going home, and often they'll void better at home where they're more relaxed anyway.
Does that help, Glenn? Okay, brilliant. Thank you, Jim.
All right, so we're going to move on to the next thing. So incontinence. This is largely about women, but not exclusively about women. Men's incontinence, the most common cause of significant incontinence is surgery, but men also get urge incontinence because of that overactive bladder, storage symptom triad we talked about, the frequency, urgency, and nocturia. So that bladder is just working so hard that when they get the urge to go, they can leak. So looking at a female bladder here, there's basically, it's a bag of muscle and basically two main reasons why particularly women will leak. So the first one is you got this bag of muscle that can work too hard, and it can have such a powerful contraction that it overcomes the resistance of the urethral sphincter and it squirts out some urine. So that is urge incontinence because they get an urge to go and they leak. Now, what should happen with a normal bladder is it fills up to roughly 400 to 500 cc's. It tells you, hey, next time we're walking past the toilet, we should drop in. And then when you're ready to go, you get to the toilet, sit down, relax, your external sphincter opens up, and the bladder does one long, continuous, smooth contraction to completely empty itself out. With an overactive bladder, it doesn't just tell you that it's getting full, it tries to empty itself. So you get a sudden contraction, which often makes people kind of drop everything. Oh, if I don't run, I'm not going to make it. And it can be painful. So bladder spasm can be really painful. Deep pelvic pain can radiate down the urethra. So that can be a powerful enough contraction that you get some leakage, and that would be called wet overactive bladder. It's often associated with bowel dysfunction, and not uncommonly, women with mild overactive bladder symptoms will come right if you get on top of their bowel habits, if they're not swinging between constipation and diarrhea, for example. But it's also not that uncommon for them to have generalized pelvic floor dysfunction. So they have some prolapse, they have some overactive bladder, they might have some stress leakage as well, and they've got some bowel dysfunction. So really useful to get a pelvic floor physiotherapist involved in that situation. It's a real spectrum. So overactive bladder happens to the majority of women at some time in their life. At one end of the spectrum, there are women who feel like they've got to pee all the time. At the other end, there are people who become hermits because they're wetting themselves the whole time and they're too embarrassed to go out. So the treatment is tailored to the individual. For a lot of the mild to moderate patients, you can identify triggers in the diet. Spicy food is a classic, caffeine, alcohol, and acidic foods and drinks like citrus and fruit juices. A trap is that there's this idea that cranberry juice is good for your bladder. So women will think, well, I've got this terrible bladder, I'm peeing all the time, so I'll get some cranberry juice. It's really acidic, and that can make your symptoms worse. Pelvic floor muscle training is useful, and that's useful for the whole pelvic floor, not just the bladder. Ovestin ointment, topical estrogen cream is also useful. Strangely, it doesn't help with stress incontinence. You'd think that if it kind of plumps up the tissue around the urethra, that might help with obstructing the urethra, holding on when the sphincter's not working properly. It doesn't, but for some reason, it helps with overactive bladder. We don't know why. And bladder retraining. So telling your bladder who's boss. So you can't say this to women who are leaking, but for mild overactive bladder, when they get that urge, just saying, hang on, I know that I peed an hour ago. I know this is my bladder playing tricks on me. This is a contraction in the same way that the uterus contracts in labor. So you get a big wave and it's uncomfortable and then it eases off again and your bladder gets used to holding a bit more. So if they can do some pelvic floor muscle training and tell their bladder who's boss, a lot of women can avoid medications. The triggers are really individual. I've had a couple of people who can't have rhubarb, one woman who couldn't have feijoas. Dark chocolate is a trigger for some people. So I'll say, when you're having a bad day, just look back over the last 4-6 hours. Did you have an energy drink? Did you have a strong cup of coffee? In terms of medications for those more moderate rather than mild cases, solifenacin is our go-to drug for this. It's an anti-muscarinic that's the most specific thing we've got for bladder muscle. So this is really a replacement for oxybutynin. It works for 24 hours, but they can have it twice a day if they've got bad symptoms. It's easier in terms of the dry mouth and the constipation, so better tolerated. And the good thing about it is they don't have to take it regularly. So I'll say to patients, if you're having a good day, skip it. But if you're having a bad day, and psychological stress is a big killer for this. So if you're going through a stressful time, or if you're going to have to sit on a plane for 4 hours, you can have one of these before you go, and it'll just make it a bit more comfortable. Still has antimuscarinic side effects. Still have to be wary in older, frail people, because if you're adding to that anticholinergic burden, you're increasing the risk of falls and confusion and all of that. There is a completely different class of medications. The one that we've got available in New Zealand is mirabegron. That's a beta-3 agonist. So no anticholinergic side effects. It works as well as Vesicare, but it's not subsidized. So it costs roughly $300 a month.
Oh.
If Vesicare doesn't work, if they can't have any more anticholinergics, if they can afford it, it's a good option. Not all pharmacies will have it in stock though. And if that doesn't work for the severe cases, we've got Botox. And this was a real breakthrough treatment. So this is where it's been around for about 25 years. It can be given at the bedside through a flexible cystoscope. I'm kind, so I give them local anesthetic as an installation for 20 minutes beforehand with an in-out catheter, and that just makes it really tolerable. It works for 6 to 9 months on average. It works for just about everybody. 5% of people naturally make an antibody against it, but for 95% of people, they'll have some effect, and it just reduces the activity of the bladder, so you're getting less frequency and urgency. It's a very rewarding treatment. People usually do really well, and it means that we almost never have to do an augmentation cystoplasty, which is major surgery, taking some bowel, opening it up into a flap and opening up the bladder and making a patch with the bowel. That used to be the only option we had. You just about never see it now. Okay, so the other reason that people leak, intrinsic sphincter deficiency. So the valve is just not working anymore. In men, that's because of prostate surgery. In women, it's most commonly because of childbirth. And in fact, even pregnancy increases the risk because there's some irreversible estrogen changes that happens to the pelvic floor. So even if you haven't delivered a baby, it can affect your sphincter. This is not so easy to deal with, and our old standard of care would have been a mesh sling. They're really easy to put in. They are not nearly so morbid as pelvic mesh, but they have been put in the same basket as pelvic mesh and hernia mesh. So there's an embargo at the moment, and if you want to place meshes, there's a very long and complicated accreditation process going on at the moment. This is fraught now. I think the water has been poisoned to the point where not many surgeons want to do it anymore, which is a shame because it was. Sorry, carry on.
Are there alternatives coming, or?
Well, so the alternative is a fascial sling. So you harvest some of the rectus fascia. It's a more morbid procedure, much more prone to complications. We have to teach the women how to do in-out catheterization because relatively commonly they won't be able to completely empty their bladder, at least in the short term. It's a much bigger deal. It completely fell out of our curriculum for about 10, 15 years because everybody just got a mesh sling. So very few people do them. It's kind of the retiring generation that used to do them, and they don't want to get involved in anything so political as this.
Okay.
There are bulking agents, so we can inject temporary bulking agents into the urethra that just don't work as well and aren't very durable. It's a bad time to have stress incontinence. Okay.
Oh.
So moving on to trauma. So if you work in a rural hospital and you've been playing solitaire till this point, now's the time to prick up your ears. The most useful tool in urological trauma would probably be the catheter. You know how to put a catheter in. I'm not going to insult your intelligence, but there's a couple of useful tricks that I've learned over the years. And one is just occasionally you can't get the fluid out of the hub, so the balloon won't collapse. And it can be that the tip of the thing's flipped back on itself and it's cutting off its own channel. You can just have a dud catheter. And if you've got that situation where there's still 10 mils in the balloon and you can't get it out, try cutting off the hub with a pair of scissors. And then usually that will eventually spray 10 mils out, and you can leave it as long as it takes. If you've got a really anxious patient who is terrified about having their catheter removed, and you will get these people that are just clamping down their pelvic floor, and it is torture for them when you move the catheter. It's like those super anxious people, you can let down the balloon and then just walk away. And eventually their moving around will mean that the thing will actually fall out. Otherwise, if you haven't got that time, Valsalva, cough, Big breath in and breathe out as it comes out. Anything you can do to try to relax the pelvic floor, because the catheter itself is not usually that uncomfortable coming out if your pelvic floor is relaxed. So the other thing is you'll sometimes get an older confused guy who's yanked on the catheter and the balloon is sitting in the urethra. If you can palpate the catheter balloon in the urethra, just get a fine needle and jam it straight through the urethra into the balloon. And it will deflate and it will fall out. Okay. So back to the anatomy
Can I just
picture.
ask around that? Are you talking
Yeah.
about going through the shaft of the penis or?
Yeah, so underneath in the spongy, so this is the corpus cavernosum. This is the
Mm,
corpus spongiosum. So
mm,
just
just
jam the
feel
needle
under
straight
there.
through there.
Posterior.
Yep. They'll
Okay.
yelp, but it's just a pinprick.
Okay.
I know. Makes you cross your legs, doesn't it?
That sounds right up my alley for people who know me well. They'll be like, oh my God, Lucinda will so be into doing that. Sadly, I only work in primary care now, so I probably won't be doing
Yeah.
that. But watch out.
Yeah. But like 25 needle, a small one. Doesn't have to be a big one.
No.
Um, so difficult catheterizations, most of the time, and I'll come back to this in a second, most of the time you won't do any harm gently trying to catheterize somebody. So if you can't, it could be that they've got a stricture or a urethral injury. The more common thing is that they've got some BPH and there's an acute angle at the external sphincter, and the catheter is just bashing against the bulbar urethra. It can even flip back on itself, and that's why it's important to make sure that you're getting urine back before you blow up the balloon, because I have seen plenty of balloons blown up in the bulbar urethra or even in the prostate fossa, and that hurts. So if you're struggling, one thing that you can try if you think that it's due to patient anxiety, and this is a classic for young people. So, I think back, my most memorable episode was an 18-year-old guy had broken both his femurs. He had no pelvic trauma. He needed a catheter. It just wasn't going in. So I got asked to help. And the whole problem was he's young with a sensitive urethra and a really powerful pelvic floor. And he just tensed up so much that he just clamped his urethra shut. So it was a matter of just gently applying pressure on the catheter and talking to him until he eventually relaxed and it just popped through. So those guys aren't going to have a big prostate. It's, anxiety is the killer for them.
Mm-hmm.
Never hurts to put in a couple of jellies and to tell them that you're doing that, because that's the magic trick you use to make it even more comfortable. And it's a real test of your bedside manner. If they've got acute prostatitis, particularly if they're febrile, if they feel like they're sitting on a red hot golf ball, if they need a catheter, you really need to put in a suprapubic. So one, it's torture to try to get a catheter through a hot bacterial prostatitis. The second thing is that you can give them a septic shower. So much better to put in a suprapubic. If they're coming to you, they're probably going to be in urinary retention because of the pain of voiding anyway. If they're not, you can just wait until they're full. So you're not going to want to put a catheter in and do a retrograde fill to put the SPC in. Just wait until they're uncomfortably full. You can do an ultrasound to make sure that you can see the bladder if you can't palpate it, and SPC all the way for those guys. So in a similar vein to pelvic fracture here, this person could have a urethral injury. They could have a complete transection of the urethra. So the urethra could just be poking straight into retroperitoneal fat for all you know. They might have a ruptured bladder. So it's possible that if you put a catheter in, it'll go all the way into the peritoneum. And I've seen that balloon blown up in the peritoneum. But even if that is the case, you're not going to make it any worse by having a gentle try with a catheter. So long as you're not forcing it in, again, couple of jellies, gentle attempt. If it slides in and you get clear urine back, then you've won. You've got a good outcome. You've got to have a higher index of suspicion for urethral bladder trauma if you've got blood at the meatus, of course. If they're voided, there's a reasonable chance you're going to get a catheter back up. They've got enough continuity for P to come down. You should be able to get a catheter back up. But again, even blood at the meatus, you're not going to increase the trauma significantly by gently trying a catheter if they're in painful urinary retention. So not much to lose. The other key finding in a pelvic fracture where there's a disruption in the urethra is a high riding prostate on DRE. You're going to be doing a DRE for these guys anyway to see if there's blood on your glove. So that's just something to pay attention to while you're in there. You can get bone fragments floating around in the bladder after a pelvic fracture. I've seen that with repairs with the orthopods. You're just, fishing out bits of bone and stitching it all up again. We're lucky that the bladder is really forgiving with trauma. Pretty much everything will heal up with enough stitches. So if they have got a transected urethra or you can't get a catheter up, they're probably going to need an SPC. That can be scary if they're in a multi-trauma situation. If you haven't got ultrasound, you want to get help. You want to get them to a center where there's people who can put a scope up if they need to. They can do a laparotomy and an open SPC placement if they need to, or at least they've got good bedside ultrasound and can use an ultrasound to guide their way in. If they're that bad, they're going to need to be somewhere with orthopedic surgeons anyway.
Jim, got
Yeah.
two questions.
Uh-huh.
One is showing my lack of anatomy. Obviously, we talk about blood at the urethral meatus, and I only think about that in men. Is that
Yep.
an issue with women? Is there anything different with women?
Oh, just that
Shorter
it's
urethra,
more,
but
yeah, it's more difficult for them to get urethral trauma because they've got less urethra.
yeah, okay.
But they can still have a perforated bladder or a bladder laceration that could be leaking blood. So it's worth making a note of. Again, you're not going to cause more trauma by putting a catheter in gently.
Okay. And second,
Yep.
the infamous high riding prostate. What
Yeah.
does that actually clinically feel or not feel like?
Well, I can only tell you theoretically because I've never felt it.
Oh, good. Okay.
But when you're doing a
You,
DRE and you swing your finger around to feel the prostate, it should be right there. It should be right down just above the anal verge. So if it's any more than that, and they've got a pelvic fracture, it's reasonable to suspect that they've got a disruption of the urethra. Again, make a note of it. Try to get the catheter in gently. If that doesn't work, they're going to need an SPC.
Thank you.
Yeah, extremely rare situation. Much more common that they'll get a straddle injury. So motorbike and they hit the fuel tank,
Mm-hmm.
climbing over a fence and they slip, getting kicked hard enough between the legs. So all of those things can cause a urethral injury. Again, nothing wrong with throwing a gentle catheterization.
Thank you.
All right, and at the Tauranga talk a couple of years ago, we talked about suprapubic placement. So you might have heard this before. This is a Bonanno suprapubic catheter. So it's basically Seldinger. So you put the needle down here with the straightened out, it's like a big IV cannula. Put it straight into the bladder. It's a great first aid treatment. They last about a week, 10 days, occasionally longer, but they can fall out. They kind of move around and they can leak and they block off really easily because it's such a small little pigtail drain. But at emergency situation, that'll do. It's going to drain the bladder, at least in the short term. We'll put down a more formal SPC when we get to them. And we've got a sort of next step up Seldinger style catheter that we can actually put a guide wire down your Bonanno and exchange that for a proper suprapubic. So what I don't like about this picture is this angle where they're kind of pointing towards the toes a bit because you really want to point straight at the floor. And that's because if you come in at an angle, and we all want to do this, right? You don't want to hit bowel. That's the one thing that you don't want to do with the suprapubic. So it's very tempting to kind of point for the feet here because you know that you're going away from bowel. But what commonly happens is you get into the space of Retzius, the space between the symphysis and the bladder, and you push the bladder down with the edge of the needle because it's bouncy. It'll try to escape your needle. You really have to transfix it with a bit of confidence, or otherwise you push it away and you just go deeper and deeper and deeper. And if you're really persistent, you'll hit Santorini's plexus, the venous plexus on top of the prostate there. So don't do that. 2 fingers above the pubic symphysis, and that's because nobody ever draws this correctly. The bit that you can palpate is more inferior than the bit that the rectus sheath is attached to posteriorly. So you feel the knobbly bit there, but it actually comes out further behind the muscle. So if you go 1 centimeter above the symphysis, you will hit the bone. So you really got to go 2 centimeters above. If you feel that grating sensation, you're hitting bone, just go a bit higher and straight up and down. You have to have a full bladder. So you've got to have at least 300 cc's in the bladder. If they're in retention, easy. If they aren't in retention, if it's, for our guys who've got chronic retention and they have an indwelling catheter, we'll retrograde, fill their bladder to at least 300 cc's. You can do that. I've had situations where a guy wasn't catheterizable, so we put the urethral catheter halfway up his urethra, pressure on the penis, retrograde fill, and it just forced water up through his sphincter. So we had a full bladder, got the suprapubic in, and then just let the catheter fall out. Okay, the good thing about these banana catheters is even if you hit small bowel with the needle, it doesn't actually matter. A little pinprick in the small bowel is okay. So you just have another crack. Bedside ultrasound is a really useful tool if you've got one. Just reassures you that there's no interposed bowel, particularly if they've had a previous laparotomy. You want to know that there's no adhesions with the bowel stuck on in front of the bladder potentially. Okay, I better get a bit of a move on. I've been prattling. So renal trauma, it's graded 1 to 5. That's everything from like a subcapsular hematoma to a split into the cortex to a deeper split into the cortex to a connection to the collecting system, so a urinoma leaking out, to a shattered kidney, and a grade 5 can be a shattered kidney or a vessel injury, and that's either an avulsion or just a big intimal tear that creates a flap and stops perfusion of the kidney. If they are a grade 1 or 2, you could keep them in a peripheral center. If they've got hematuria, give them a catheter, give them bed rest, observation for a couple of days. These guys are always fine. It's really when you're getting up to like the grade, potentially grade 3 if they've cracked a vessel, or grade 4, that you really want them in a bigger hospital so they can be observed. If the urinoma is not getting any better, we'll put a stent up. If we don't do an endoscopy at the time of the injury, we'll often just put a catheter in to reduce the pressure on the kidneys and let it heal up conservatively. We almost never do a nephrectomy nowadays. If we can't treat it with interventional radiology techniques, we will, but we're even doing less IR than we used to. A lot of these guys can just be treated with rest. So very rare that we've actually got to remove a kidney.
Jim, in which situations would you suspect renal injury, and how quickly do you have to transfer? Like some of our guys do have CTs, not all people. But so say if one had a CT versus not having a CT, when would you refer them on?
So mechanism and hematuria. If you suspect it, if you haven't got a CT scanner, you got to send them somewhere that does. Because particularly if they're young, they'll compensate for a long time before they drop their pressure. So yeah, mechanism, hematuria. If you can't do a CT, send them somewhere where they can get a CT. And then once the CT is reported, if it's a grade 3, I'd get on the phone and get them transferred. If they're hemodynamically unstable, don't even wait for a CT. Get them to a center where they can be definitively treated as well. So somewhere with interventional radiology. Antibiotics are a little bit controversial with the grade 4s and 5s. Some people would say, well, there's urine getting out into the tissues, but it's sterile urine. So I'm not particularly bothered about routine antibiotics if they became septic, obviously, and they'd need a stent. But I mean, if they're that bad, they've probably had some general surgery input as well, and they'll probably be on antibiotics, but that was somebody else's decision. If you do a CT and you suspect a renal injury, but they don't do delayed phases, which happens all too commonly. Often, if it's a junior reg doing the CT, they'll do a standard CT chest abdo-pelvis protocol, which isn't delayed phases, looking for urine leakage. So if you think that there might be leakage you can just do a plain film after the CT because contrast will leak out into the retroperitoneum and it hangs around for ages. So just a plain film doesn't even have to be erect. That'll show you if there's patchy contrast in the retroperitoneum. There's a thing with small children where they are so flexible that if they have a significant deceleration injury, like a lap belt would be the classic, they go firing forward, they can actually snap their kidney in half. And again, they'll compensate really well until the last minute. So yeah, high-speed kid, poorly restrained, lap belt, just keep that in the back of your mind that they can have a significant renal injury. All right, ureteric injuries are really uncommon in isolation, unless they're being caused by surgery. Penetrating injury, a knife, a gunshot can do it, but pretty uncommon. You'd pick that up on a CT IVP to, again, delayed phases. And again, that kind of injury, they're probably heading towards a tertiary center anyway. If they're not, if you pick up a ureteric injury, then you'd go to somewhere where there's a urologist. So this was the pause for questions slide. Anything that we need to talk about before we go any further?
No.
Okay.
Totally up. All good, Jim.
I'm aware that time is marching on, so I'm going to talk a bit quickly about kidney stones. So this is a big staghorn calculus.
Don't panic too much about time as long as you don't have to bolt, because everyone hangs around for about an extra 10 minutes if they've, so don't panic too much. Thanks.
All right. I'll
Don't race for the sake of racing. That's what I'm saying.
Okay, I'll have my clonazepam drops and take it easy. So yeah, this is a trick that we do with our registrars, is showing them a shot of a bilateral staghorn calculus, and they report it like it's a CT IVP because they forget to ask, is this a contrast CT? So they do get this big. Kidney stones are reasonably common, but are often asymptomatic. So a lot of people are walking around with small kidney stones. They'll never know about it, particularly if they're in the lower pole of the kidney, because gravity tends to keep them there. We don't electively go up after kidney stones unless there's special circumstances, unless they get to at least 8 and maybe 10 millimeters. And in the lower pole, the latest American guidelines are you just kind of keep an eye on them until you feel like doing something. If they come out into the ureter, that's when they will generally become symptomatic. So I guess you want to know when you need to send them to a tertiary center with urology. So reasons to do that would be if they have a big ureteric stone, so more than 6 millimeters, particularly if it's proximal when they present. So the higher up in the ureter the stone is when they present, the less likely it is to pass spontaneously. So an 8 millimeter stone that's at the vesico-ureteric junction is more likely to pass than a 6 millimeter stone that presents when it's up in the PUJ. You can hang on to them. In fact, sending them home is a great idea because mobilizing is useful for getting the ureter working. Send them home if it's 6 millimeters or less, no sepsis, that's a key. If they have 2 functioning kidneys, so we talk about if they've got a solitary obstructed kidney, that's bad, but we're talking not just anatomically solitary, but if it's functionally solitary. So I've had a patient this week who had a stone on this side and a multi-cystic kidney on the other side that doesn't do anything. So she's essentially got 1 kidney. Or if their overall kidney function is so poor that they're operating as though they've got 1 kidney or less. And if they can control their pain. So that's kind of the softest indication for us to intervene acutely. But if they've got intractable pain, then yep, we'll see them for a stent. If they've got a urinoma, so the stone has blocked the ureter and the back pressure has meant that a calyx is ruptured and they have a collection of urine in their retroperitoneum, that's actually fine. You just treat it in exactly the same way. That'll resorb, it'll heal up. So don't be alarmed when you see, the radiologist will sometimes say ruptured kidney, and it sounds scary, but it's actually fine. The most effective analgesia for renal colic, according to RCTs, is PR diclofenac. So a Voltaren suppository is the best thing. Opiates tend to just make them feel awful and they're not particularly effective. Oral anti-inflammatories often don't work so well because their gastric emptying is affected by the pain. So people who have recurrent stones, our patients that we get to know well, they're always very keen to have a supply of Voltaren suppositories at home, and they'll take care of themselves because it's faster than going to the ED. There is mixed evidence for using alpha blockers. So there are alpha receptors in the smooth muscle of the ureter, and the theory is that if you give an alpha blocker, it relaxes the ureter and helps stone passage. There were some RCTs that showed that that was the case, reduced pain, improved the chances of spontaneous passage. Then there was a real life study done through EDs in the UK, which showed that there was no difference. Our problem with that study is that they gave alpha blockers to people with stones no matter where in the ureter it was. And we know that there are no alpha blockers in the upper third of the ureter. So we would expect that alpha blockers wouldn't work for those people. And we think that it was the dilution of those patients that reduced the significance of that study. So I think there's nothing wrong with giving an alpha blocker for somebody with a distal ureteric stone. There is some evidence that it works, and it's great to have a drug where you can say, this is how this drug works to reduce your pain and improve your chances of passing the stone spontaneously. It's great coaching for the patient. I'm not going to dwell too much on this, but 80% of stones have calcium oxalate in them. These are some of the high oxalate foods. What we know from big population studies is altering your diet to reduce oxalate makes very little difference in stone formation. And by far the most important thing is hydration. So the only people we really talk to about reducing oxalate in their diet is people who are metabolically active, growing stones every 6 months or so, where you're trying to throw everything at them. But the most important thing is drinking until the urine is clear, and then it's not concentrating those crystals, and so it's not growing the stones any bigger. I don't give people a volume that they should aim for because it's really individual. And if you're a small, frail 80-year-old lady, you probably don't need to drink 3 liters of water a day. Much better to just monitor your urine, see if it's clear. If it's not clear, drink more. After an episode of a kidney stone, there should be just some basic screening bloods done. So renal function, uric acid, because 15% of stones are urate. So people who have gout can also grow kidney stones. Even calcium-based kidney stones can start on a uric acid crystal. Check their calcium level. It's important that they've got normal calcium because high or low serum calcium and high or low dietary calcium can increase your risk of stones. 80% of the time, you're not going to find any metabolic abnormality. It's not very rewarding, but for 1 in 5 patients, it might make a difference. So if the stone's not budging, sepsis, pain, solitary kidney, send them to us and we will, depending on the case, either put a stent up to bypass the stone, allow kidney drainage, allow drainage of sepsis, or if they're not septic, we'll sometimes try a primary ureteroscopy. So try to just go in and take care of the stone with a laser right off the bat. That doesn't always work. Your ideal candidate is somebody with a distal stone. Female helps because men have a bulkier psoas muscle that makes it more difficult to get over. Not too big, and during hours where we've got a nurse who's qualified to operate the laser for us. So that's, the later in the day it gets, the less likely we are to be able to do that. So a lot of our patients will end up with a JJ stent, which is irritating. They'll often get pain when they void, when they exercise. The voiding pain is because the pressure from the bladder is transmitted up to the kidney because you've bypassed the flap valve. They get blood in their urine. They feel like they've got to pee all the time. It's unhappy. And we know that antimuscarinics like solifenacin and alpha blockers both help with stent discomfort. And myself, if flank pain's the main problem, I'll give them an alpha blocker because that's going to work on the smooth muscle. If bladder symptoms is the main problem, I'll give them solifenacin. It's just no fun having a stent. The answer is to just hurry up and get on with your definitive procedure. I've got a bit about small renal masses here, but I think there's probably more useful stuff we could go on to. Suffice to say, if there's an incidental finding of a small renal mass and it's less than 4 centimeters in size, there is less than a 1% chance of it having metastasized. So we're very relaxed about surveilling small renal masses. They grow on average at 0.23 centimeters per year. So if somebody's got a 1 centimeter lesion in their kidney, it's going to be several years before it gets to the point where it's risking metastasizing. So that's why we're quite relaxed about small renal masses. Renal cysts, 50% of people over 50 have got at least one. If it's a Bosniak 1 or 2, it's a nothing. Doesn't need surveillance. If it's a Bosniak 2F or above, the radiologist will say this needs follow-up. Often it's just another ultrasound in 6 months or so because they can't quite tell if it's got a solid component to it. 4s and 5s are probably cancers and would treat them like a small renal mass. So if they're small enough, we just keep an eye on them. Okay, so getting on to hematuria, this is probably something we can get a bit of value out of. 15% of people have microscopic hematuria. Only 5% of them have a malignancy underlying it. So once we've worked up a person for painless microhematuria once, we don't do it again because they'll probably always have it. So if you've got a 20-year-old with microscopic hematuria, if they've got no risk factors, so no industrial chemical exposure, no smoking, no family history, then we'll just do urine sample cytology or CX bladder imaging, and they usually don't need a cystoscopy. Women up to the age of 40 don't need a cystoscopy for microscopic hematuria that's low risk. Men 30, because men are more likely to get bladder cancer. Most people that we see are over 40, so they're getting a cystoscopy. Macrohematuria is a really different story. So 1 in 4 men over 50 who have macroscopic painless hematuria have cancer. So much more common. Keep in mind that's painless hematuria. So if they've got renal colic, if they've got prostatitis and they've got hematuria, that's not painless. So you'd wait until the dust settles, till they've passed the stone, until they've gotten over their infection, see if they've got persistent hematuria after that. Microhematuria is not an explanation for anemia, by the way. We're talking tiny amounts of blood being lost in the urine. So if they've got anemia, look for another cause. We had a question during the week about macroscopic hematuria and clot retention as an inpatient. So with clot retention, it's usually men. It's less common in women. If it's women, it's usually bladder cancer or some systemic coagulopathy. So much more commonly, it's men with either BPH. As the prostate gets enlarged, it grows big fragile veins, or prostate cancer or bladder cancer. So the important thing is getting that clot out of the bladder. The clot is thrombolytic in its own right. You might remember from medical school that the clot sows the seeds of its own destruction. So while there is still clot in the bladder, they're never going to have good hemostasis. It's going to be dissolving, releasing urokinase and dissolving the healthy clot that's trying to form over the ruptured blood vessel. So the clot's got to come out. Big catheter, so 22 French or above. The washout that happens at the beginning is a completely different proposition to continuous bladder irrigation. And this is something that we not infrequently have problems with in our EDs with nurses who aren't experienced and are also really under the pump. So they've got a lot of patients to deal with. So a bladder washout means standing there with a catheter tip syringe and as much saline as it takes to keep irrigating out that clot until there's no more clot to irrigate. And your first couple of tries, you might not get much out. You want turbulent flow, so forcefully putting in 10 or 20 cc's at a time, pulling back in a sort of jerky motion to get that clot bouncing around and breaking up. It's unpleasant for patients. They'll often need some pain relief. Some solifenacin is really nice because then the bladder is going to relax a little bit. It can take over an hour to empty out a bladder full of clot. It just takes as long as it takes, and you can see why nurses in the ED are not in love with the idea of doing it. But you've got to do that before you start the irrigation or you just don't win. And one of the worst cases I've had was a guy who was transferred from a peripheral hospital in clot retention. Catheter went in, they put up the irrigation. He's in screaming agony. Took hours for him to get transferred in the ambulance. The ambulance had the irrigation running. He's just having overflow incontinence around the catheter. It was torturing the poor guy. It would have been kinder to just pull the catheter out. So irrigate as long as it takes. sometimes you can't win and they need a GA, and we'll go in with a rigid cystoscope. So we've got a metal tube into the catheter and we can get some real force down that thing. We can even use a diathermy loop to cut up clot. It's rare that we need to, but we've got those tools in the kit. So washout first. Once the washout is complete, once you're happy that you've got the clot out, you can give them tranexamic acid. So again, when I was a registrar, we'd say that's contraindicated because, well, you're going to set that clot like concrete. You're not going to be able to get it out. Once you've got the clots out, it's not a bad idea to give them TXA. And we're really confident now that it doesn't increase the risk of thrombotic disease. So it's pretty safe to give that. And we'll sometimes give it to outpatients, older guys who've got BPH that we can't treat, who've just got a catheter in. They can have a low dose of TXA every day to keep them out of hospital. Continuous bladder irrigation is like tuning shortwave radio. So you don't want it running perfectly clear because all you're doing in that case is washing out all your clotting factors. You don't want it running dark enough that you're going to form blood clots in the lumen of the bladder. So you want like a light rosé, and that's going slow enough that those ruptured vessels can start to heal up. There was a question about when to remove the catheter after you've been dealing with clot retention. And it's a little bit of trial and error. So what you do is get to the point where you can turn off the irrigation and it's a light rosé, no clots. Mobilize them because sometimes they'll get out of bed, the catheter moves, and they're back to bad hematuria. So if they can walk around and it's still reasonably clear with no clots, then you can get the catheter out. I think if you've had a good 48 hours and you're still not winning, you've still got irrigation running, it's probably time to talk to a center with urologists. Okay. I think we've just got the traps now. So this was an idea I got from a gynae oncologist that I was talking to once during an operation about ovarian cancer and how it seems very sneaky. And he said, it's the people that keep coming back. So pelvic pain's common, but if women keep coming back, that's when you get the scan because those are the ones that you can overlook. So that made me think about things that can catch you out in urology. So one is not checking the PSA with lower urinary tract symptoms. And we've kind of inherited this history of prostate cancer being overtreated and treated late. So we had the worst of both worlds. We were giving people the side effects of treatment that was not effective because it was too late for them. So that meant that some people were resistant about doing PSA testing. Now, whatever your stance on screening is philosophically, if somebody's got lower urinary tract symptoms, doing a PSA test is not screening, it's a diagnostic test. So it's the same as, you might think the value of mammography screening is pretty low, but if somebody's got a breast lump, you're not screening them, you're doing a diagnostic test to see what that thing is. So it's worth getting a PSA in somebody with low urinary tract symptoms. Rare exceptions would be somebody where you really don't want to know if they've got prostate cancer. So a frail 90-year-old, it's adequate for you to just do a DRE. And if it doesn't feel like a nasty prostate cancer, that's okay. Somebody with a less than 5-year life expectancy, you probably don't want to know. If they do have palpable cancer, then they might benefit from some palliative hormone deprivation. So PSA for almost everybody with LUTS. And I talked about this before, missing that overflow incontinence, men saying, oh yeah, I've been wetting the bed lately. Don't just give them antibiotics empirically. Feel the prostate, feel the tummy, see if they've got a big post-void residual. This is one that any urology department in the country has got a policy of no review of renal colic without a CT scan. And it's not just us being precious, it's because there are so many things that can mimic renal calculi. And when I was a registrar working at Tauranga, overnight it would be the junior gen surge and ortho regs on call. And the rule was that they weren't allowed to admit anybody with renal colic unless there's a CT scan, but of course they did. And so that year in the morning, I came on to a guy with an obstructing sigmoid cancer. There was somebody with metastatic gastric cancer. the orthopedic reg-on overnight admitted somebody with mechanical back pain and another guy with lymphoma, and they all had classic renal colic clinically. And then once they've been admitted under the wrong team, you all know how dangerous it is to be under the wrong team in hospital. So the first time they've got stones, and if they're really young or really old, you probably want to get some imaging, because it's just a bit weird to get your first kidney stone in your late 70s or at 12. We had a case in Wellington a few years ago where somebody was sent in with query bilateral renal colic, and the guy had a ruptured AAA, and he died on the way to hospital in the ambulance. And don't forget a pregnancy test, because it could be pregnancy related. And as well as being an ectopic, it can be a torted ovary. There's all sorts of things that mimic renal colic. I think that's it. I haven't got much more to add. Oh, painless hematuria. Yeah, so we talked about how micro painless hematuria is a low risk for malignancy, macro much higher. There is still always a risk of malignancy, so we need to get to the bottom of painless hematuria. It's not normal to have painless hematuria. We've got to find out what's going on.
Is that macroscopic?
No, any. Even the micro. It's low risk, but not no risk. So we've always got to know.
Okay.
So they've got to be worked up once. All right, I'm losing my voice, so we must be getting to the end.
Yeah. Has anyone got any questions quickly to go into the chat around any of those traps, pearls at the end? Speak now, forever hold your peace.
I just had a question around
good.
renal colic.
Yeah.
How much do you take into account in terms of the size of the stone versus if there's like hydronephrosis or hydroureter? Where does all of the sort of thinking around that come from?
Yeah. So at any point, even with a small stone, if you scan them at the right time, you're probably going to get some hydro, because there'll be intermittent obstruction as that ureter is squeezing the stone down. It's going to be squeezing onto the stone, and it will, even if it's just for a few seconds, it's going to obstruct. So you might get a bit of hydro. If it's a small stone with hydro or a urinoma, if it's 6 millimeters or less, it's fine. I mean, there's some departments around the country that won't follow up patients who've been diagnosed with a stone 6 millimeters or less. I think that's somewhat risky. If it's a proximal stone, I would want to know that it's passed. But that's pretty low risk. I mean, we'll sometimes, my registrar on call last week phoned up and he said, I've got a lady here who's got a 9 millimeter proximal ureteric calculus, first presentation. And I was like, yeah, okay, we're going to have to stent her. That's not going anywhere. It's proximal, it's big. We might as well get her on the list now, because we could send her home for a week, but it's not going to make any progress. So if it's distal, if it's 6 millimeters or less, we're very relaxed. If you're seeing them in the ED, I think it's reasonable to say up to 8 millimeters and distal, you can send them home and they can have a crack, because not uncommonly, it's like a football shaped stone, and it might be quite long, but not that wide. And it can go like a bullet down the barrel of a gun and still be passed. I remember seeing an 18-year-old female, a small female, a refugee, who had a 15 millimeter stone that she passed spontaneously because it was only about 5 millimeters wide.
And then David's just put in there about, is there any relevance regarding the size of the stones and the low ureter and the benefit of alpha blockers? I think is how we interpret that question. Does that change it, or is it just more location?
Yeah, you can give anybody an alpha blocker, and you're unlikely to do them harm. It's probably going to make them more comfortable, even if they don't pass the stone. So give it a crack. The other thing that I'd say about dealing with people with stones is they'll often have some renal impairment, and as well as, a bit of obstruction shouldn't cause much renal impairment because you've got another kidney, right? Most of us could donate a kidney and our renal function would be fine. There's like a reflex vasospasm of the renal arteries, which reduces flow. That's probably the cause of renal impairment. They'll also not uncommonly be dehydrated because they're too sore to drink, and they've been vomiting in some cases. When you send them home, they just drink to thirst. So don't get them to guzzle a whole lot of water. Like you sort of think intuitively, well, the more water, the more likely it is to flush it out. If you give them a significant diuresis, it actually reduces the ability of the ureter to coapt efficiently. So it kind of floods it open and it can't squeeze so well. So just drinking to thirst.
Interesting. Good. Oh, Glenn, you snuck in there. Okay. Oh, this is people. Okay. Can you see those there, Jim? Small
I'm
distal
just,
stone, 3 to 5 millimeters
yeah,
from discharge from ED. I asked that
yeah,
same question, Glenn, not
yeah,
necessarily sieving urine anymore. Don't come back if no pain, repeat imaging, and then urate when to initiate treatment. If we answer
yeah.
those
So,
3 questions quickly, Jim, and then that will be us, please.
okay, yep. So we talked about the size of stone. So distal ureter, just you could do it to anyone, but if it's kind of bigger than 8 millimeters, I'd make a referral for follow-up for sure. If it's a small stone, 3 to 5 millimeters in the distal ureter, yeah, they're okay. Only come back if the pain returns or if they're septic. Checking the urate. So yeah, it's got to be done at some stage. And if they've had an acute bout of renal colic for a few days and their oral intake's not normal, wait for the dust to settle and then do your screening tests. So not everybody needs allopurinol. If this is a one-off, so most people who have one kidney stone have an 80% chance of another kidney stone that's symptomatic within 10 years. That means a lot of people are going to be waiting several years before they have another one. If they're metabolically active, like I said, if they're growing stones every 6 months, you throw everything at them. If it's a second presentation and they're prepared to take a daily medication for a problem that only pops up every couple of 3 years, that's fine. A lot of people just stop taking it if they haven't got gout symptoms as well, because they forget how bad renal colic is after a few months. Uh,
Mm.
so the thing about uric acid stones is that they're the one type of stone that's amenable to medical management. So with really good hydration and with alkalinization of the urine with like urine sachets, you can shrink down a cubic centimeter of stone per month if they're really motivated. So you can do really well with non-intervention with uric acid stones. So more important than the allopurinol is really good hydration. So no, I wouldn't start it on everybody. It's a risk benefit calculation that you do with the patient. If stones are a regular problem for them, then yep. If it's once every 10 years, are we getting people to sieve urine? You can if they're really motivated. I mean, most of the time now, we can get a pretty good idea of the composition of the stone from the Hounsfield units on CT. So if they're motivated and they're interested to know what the stone is, then yeah. And I guess if you found that it was uric acid, well, you'd know that from the Hounsfield units, but it means that you could say to them, hey, these are really amenable to good hydration. So, maybe there'd be some motivation for them.
And
Um,
Jim, just to confirm, in terms of the targets for the uric acid level, if you're using allopurinol, or is it just
yeah,
symptom
just,
driven?
yeah, same as gout.
Okay, great. Okay, everyone, I will make a call there. Thank you very much for your input. Thank you to Jim. Really appreciate your time this evening. And also to Ralston, thank you for coming in and supporting me. I would love it if you could all fill out the evaluation form. Last time we had a really good input on that. And so if any other comments about further webinars going forward, I would really appreciate it. If you do fill it out, put your medical counsel number on. That offer's only tonight. So don't message me tomorrow or next week. I'd really appreciate that. Thank you, David. Yes, I always appreciate your input on topics. So vascular is coming up though. That is going to be our next topic in August with Ruth Benson. So look forward to seeing you all then. Thank you very much.